Hello, my name is Darren Hill, and this is my presentation on staffing and scheduling, which is Chapter 17 in our textbook. Staffing and scheduling are important aspects of the nurse manager's role. Staffing and scheduling are also important components of job satisfaction for staff nurses. Decreasing nurse-patient ratios are associated with higher patient survival rates, and inability to meet patient needs with nurse skill levels can increase patient mortality. The goal of staffing is to provide the appropriate number of nurses and appropriate skill mix to a patient population. Patient classification systems are generally utilized to appropriate staff that's available. There are some mathematical formulas utilized to demonstrate staffing mix and staffing distribution, and a variety of methodologies are utilized to schedule staff. The goal of staffing is to provide appropriate number and mix of nursing staff to meet actual or projected patient care needs. No method is perfect at predicting this, and there's definitely some real-time fine-tuning that is required to optimize staffing. The Joint Commission requires that the right number of competent staff be provided to meet patient needs. Interestingly enough, all the Joint Commission really requires is that a facility has some sort of model in place and that they meet their own criteria for selection. So how do we do this? Generally, we use a patient classification system. We use patient needs to objectively determine the number of staff needed to care for that patient population. Generally, we collect this data at the midpoint of the previous shift to determine what we need for the next shift. Many facilities use the electronic medical record. They pull data points to create some sort of score that tells you how acute a patient is and what kind of staffing they need. And this allows for some dynamic staffing changes based on the patient population and the availability of staff. Part of this is determining nursing care hours. As we analyze workload trends, we look at each day, possibly in a medical surgical unit, each hour in critical care, or some facilities use a diagnosis-dependent score for acuity. There are no current specific standards for nursing care hours in any type of patient. Again, this is organization identified, but I have an example to the right to give you an idea. 26 patients, each assigned an acuity level between 1 and 4. As you can see, 26 patients total, different acuity levels, how many are in each level, and the total hours of care required is 161. If you divide the 161 hours by the 26 patients that are on the unit, you have an average of 6.19 nursing hours per patient day that are required to meet those patients' needs. This helps you to plan an FTE workforce. Positions are defined in regards to a FTE equivalent, which is 40 hours of work per week, or 2,080 hours per year, considering 52 weeks in a year. Each one of these FTEs can be filled by one nurse working their full 40 hours, or it can be a combination of nurses that compose one FTE. And there are a number of ways of determining the number of staff required on a unit to staff at 24 hours a day, 365 days of the year. Sorry for the 265 that I have published. An example, there's a number of calculations. Essentially, they all give the same data. In this example, you have 80 hours in an FTE, 14 days covered in 2 weeks, average daily census of 26, and a number of nursing care hours of 6.15. The formula is below. Take the average nursing hours, days in staffing period, and average patient census multiplied together, divided by the hours of work per FTE in a 2-week period. Crunch the numbers, you end up with 27.98 FTEs, or 28 FTEs. So that would be how you determine how many FTEs you need to staff a unit for an entire year. Determining distribution of staff and block staffing. It's important to consider weekly and daily patient census fluctuations. You need to consider the unit type. So a surgical unit, generally you have shorter length of stay, higher census in the beginning of the week, you have more surgeries, by the end of the week you discharge patients, you're lower on the weekend. Medical units tend to be more standard in their number of patients, but sometimes drop on the weekends because we don't do as many diagnostic tests on the weekends. In critical care, you need to consider hourly fluctuations in care. In the morning, you may have patients that are now ready to leave the intensive care unit, more staff are needed to transfer and call report. In the afternoon, you have complex surgical cases starting in the morning, they're done, they come to the unit in the early afternoon, you need more staff to get those patients in. Block scheduling is also sometimes required. It's a different methodology, generally emergency departments, trauma units, etc., where you can't really determine the number of patients. It's completely variable. You may have a snowstorm, there may be more car accidents. It may be a weekend night, and you have more alcohol intoxication related injuries. So you need to staff a certain number of nurses to compensate for the projected number of patients you could potentially have. A number of scheduling models are adapted. There's nursing shortages and budget constraints that lead to creative staffing models. Example of that is just variable shift lengths and different coverage options to accommodate for census and units. A lot of facilities implement a self-staffing or self-scheduling model. This helps improve nursing satisfaction. We know there's a shortage, but it gives nurses a ability to have some empowerment in their role and defining their schedule. The benefit of this is that you can have higher staff morale, but the manager's role is important here. There needs to be an early choosing of shifts. The manager needs to take their time, go through, make sure that all the unit staffing needs are met, adjust as needed, and then they need to post the schedule in a timely manner so staff isn't dissatisfied when the schedule comes out too soon and they've been moved. There's also the idea of a shared schedule where two people may split their hours in a shift. If it's a 12-hour shift, both of them may work 6 hours. They need to be paired for this, but people that have obligations outside of work that they need to attend to, young kids or close to retirement that still want hours, sometimes this model works for them. Many facilities use an open shift management idea where they have unit-wide or hospital-wide open shifts posted, and different nurses from different units or nurses within the unit can look at open shifts, pick up beyond their FTE, allows them to generate more income. The big thing here is you need to have some kind of supervisory body or nurse manager role that can determine whether the nurse picking up has the right skill match to take care of the patients where they are picking up. There is some mention in the text regarding weekend staffing plans. It used to be that you could downstaff on weekends, you could downstaff at night shift, because there was just less tasks to do and less patient population. As care moves more to outpatient, we're managing complex patients outside of the hospital in doctor's offices, home visits, etc., telemedicine. The patients that are inpatient are truly acute, so this is not a model that really works anymore. There's no real evidence to back up the idea of downstaffing on weekends and nights. I pulled up an article by Aiken and his colleagues. Essentially, it states that there is strong evidence of a significant association between better nurse staffing and lower mortality. I've included the graph on the right, expected deaths per 1,000 discharges on the left, and nursing staffing, patients per RN. On the right, 4 per RN. On the left, 14 per RN. You can see there's a pretty linear curve talking about the expected number of deaths based on the number of patients assigned to each nurse. Each one patient added to a nurse's workload is associated with a 7% increase in risk-adjusted mortality following general surgery, and poor staffing ratios often result from this burden, this financial burden that's implied by having more nurses on staff. There is some discussion in the article about how having more nurses actually decreases the number of additional procedures, laboratory tests, decreases length of stay, and actually tends to outweigh the costs that are associated with those. So this really highlights that there's an extreme importance in implementing appropriate acuity assessment models and identifying the correct patient care hours. You don't want to be in a situation as a facility where you're actually paying more to do more procedures and keep patients in the hospital longer than you would be paying more nurses. Nurse staffing and nurse outcomes. That's important to consider also. It's not always just about patient outcomes. Studies tie higher nurse-patient ratios with higher incidence of negative nurse outcomes. For example, nurse burnout. There's an increase by one patient per RN is associated with a 7% increase in the odds of nurses reporting burnout. Job dissatisfaction increases by 8% for each additional patient that an RN has to take care of. Intention to leave a facility is increased by 1.05 times with each patient that is added. They also included needle stick injuries, but there was no statistical significant correlation between needle stick and number of patients. But it's important to note that greater nurse-to-patient ratio is definitely related to an increase in adverse nurse outcomes. I've included a video, a little bit of discussion about implementing a acuity-based staffing model. It's a little bit older. I think that that's a more common practice now, but it's still interesting to see that it's important for staff nurses to be involved in this process too and really advocate for a acuity-based staffing model It's important for nurse managers to include staff and listen to them and their expression of, possible job dissatisfaction.
Leanne has been a charge nurse on our unit, which is a 36-bed OBGYN unit. The staff were really frustrated because they felt like they were taking care of an incredible load of patients, and not only a high load of patients, but the acuity was very high.
We did not use acuity for staffing the unit, but primarily looked at using just the number of patients in the beds.
We have always struggled with how do we show the work that we do on the unit and be able to staff the unit as well as be able to fall in budget.
When I decided to do the project, I knew that I had to have budget on my side. So you have to be budget savvy. So I decided to meet with Ann Underhill in finance and kind of explain to her, this is what my goal is. I want to create an acuity tool that's going to capture the types of patients that we take care of.
She came to me because she wanted to address the issues on 4 East, which is postpartum, because you had sick antepartum, you had postpartum, and you had GYN oncology.
The main obstacle was, what did I need? What did I need to show them for them to understand, rather than me just to say, I need more help?
She went back and pulled months worth of data and did a basic analysis with that basic structure of what should the ratios be, and how should we have staffed, and how many nurses should we have had on the unit.
So the acuity tool actually gave a concrete way, a consistent way to show these are the types of patients that we take care of, and this is the amount of nursing care that we need to take care of those kinds of patients. And because of that, we not only increased our nurse satisfaction, we increased our patient satisfaction and our patient quality of care.
I think what the program brought to it is that it helped Leanne figure out a way to address the problem in a way that wasn't based in emotions or drama or, oh, this isn't working. It really pushed her into looking at how's in a way I can be an effective businesswoman.
I think Leanne showed us that with the right support, with the right issue, I guess, that you can actually move things forward as a staff member versus having to wait for your manager to do it. When someone like Leanne is able to take a project and show how do you use real skill and real technique to identify a problem and create a solution, not only is it a great understanding and learning for that individual, but it's great for the organization.
I've included a link here if you choose to pursue it. It's from the American Nurses Association. It's in regards to nurse staffing. Just talks about how you can advocate for your unit, gives some demonstrations of models and acuity-based tools, how to create them. It really just builds on this entire presentation. It's just a very basic understanding of how this all works. American Nurses Association advocates for better nurse-patient ratios, so excellent resource available if you choose to pursue it. I also included this slide. Griffiths and his colleagues made an article really assessing nurse staffing and nursing assistants. There's been a big push from some organizations to compensate for lower numbers of nurses by adding more aides. I know that my facility chose to demo a 5-to-1-to-1 ratio, 5 patients, 1 nurse, 1 aide, and generate data, see how this works. They took some time and really looked at the hazard of death in correlation to the number of patient care hours provided. They looked at nurses and they looked at patient care assistants. Their argument is that essentially as there's a sweet spot for nursing assistants, and really there's a linear progression, as you can see in the graph on the right, between number of hours the nurse was able to spend with the patient and the hazard of death increase. Less hours, of course, higher chance of death increase. Very linear, more hours, less chance. As you can see from the nursing assistant portion, the orange dotted line though, there's kind of a sweet spot there. Less is obviously worse, but as you increase the number of aides, you actually have a higher hazard of death if you're looking at just the nursing assistant models. I've also included references. Thank you very much for your time.